So we're going to talk about bowel obstruction, different things that can cause bowel obstruction. We talked about herniations, we talked about fecal impaction. I want to talk about another phenomenon that can cause bowel obstruction. It's called intussusception. There's a little diagram of it. Intussusception is a condition where a proximal segment of bowel will herniate into a distal segment of the bowel. And you can see this is an example here in diagrammatic form. It's often described as a telescoping phenomenon where this proximal inner segment can prolapse right into the distal segment. When this happens, you can see there's a couple of problems here. We're going to develop an obstruction there. We're going to kink off the circulation in certain areas of the bowel. So there are two problems with intussusception. Number one, you get a bowel obstruction, and number two, this can lead to bowel infarction fairly quickly. Now, the most likely cause of intussusception depends on the age of the patient. If a patient is very young, they're pediatric, usually intussusception is caused by hyperperistalsis. Very strong peristaltic action is driving this proximal segment to the distal segment. Usually it's hyperperistalsis in a child. In an adult, usually there's some sort of intraluminal mass, maybe a polyp or something that's hanging down from the wall of the bowel. Peristaltic wave comes down the bowel, grab hold of the polyp, and pull the entire bowel into the distal segment. And so in an adult, the most likely cause of an intussusception would be some sort of intraluminal mass. Okay? So the cause of this really depends on age. Hyperperistalsis in a kid and intraluminal mass in an adult. Whatever be the case, you get a bowel obstruction. The bowels also become ischemic. Usually an intussusception will classically present as a sausage-like mass on palpation. That's how it's described. Sausage-like mass. The procedure to correct this is not only therapeutic, it's also diagnostic. Usually we give an enema. If you give an enema, the back pressure will cause this herniation to be reduced. Then we have to figure out why the intussusception occurred. Again, usually an adult will see some sort of internal mass, but a filling defect that you can obviously see. In a child, you probably won't see it because most of the time that'll be caused by hyperperistalsis. Okay, let's take a look at an obstructed bowel. What an obstructed bowel would look like radiographically. And first take a look at the normal bowel. So here's an example of an upper GI series. This person was asked to swallow barium. They allowed the barium to go through the stomach and the small bowel. Of course, you can see the stomach here. There's the duodenal sweep. And you can see loops of small bowel throughout. You recognize there are these perpendicular filling defects. Those are the plicae circulare. The bowel is of normal caliber. You can compare the caliber of the bowel to the vertebral column in the back, and you can see that everything is normal. Everything is within reasonable size. Everything looks good. When the bowel becomes obstructed, gases cannot pass distally. As a result, gases will accumulate and cause massive distension of the bowel. And that's going to be one of the presenting features of someone with an obstructed bowel, whether that obstruction be mechanical or functional. This is what the bowel looks like when it's obstructed. Again, we got an upper GI series here. And again, you can see the loops of small bowel. You can actually see the plicae circulare in the bowel. If you trace the bowel, you'll notice that the bowel will end abruptly here. Okay? After this point, you can't see the bowel at all, and that's because contrast agent has not been allowed to pass distal to this point, and therefore the bowel blends in with all the background tissues. You can't see it. This is a point, of course, of obstruction. You'll notice that the bowel is extensively distended, very distended. This, of course, is, again, one of the presenting features of bowel obstruction. People with an obstructed bowel, generally they're vomiting. Depending upon what you see in the vomit, might give you a clue where the obstruction is. If there's an obstruction proximal to the ampulla and the duodenal sweep, the vomit the person's producing will not have bile in it. If, however, the obstruction is distal to the ampulla, then the vomit will probably be bilious in nature. We'll see actually some bile in the vomit. Okay, that might give you a clue as to determine whether the obstruction is affecting the upper GI or perhaps lower GI tract. Okay, any questions on that? Another form of obstruction, volvulus. This is a condition where the bowel twists on itself. There are two patterns of volvuli. You have the typical volvulus and you have axial volvulus. Typical volvulus occurs when a loop of bowel twists on its base, resulting in an obstruction. Something like this is very common to see in the sigmoid colon. Sigmoid colon has a lot of redundant length to it, and there's an opportunity for a loop like this to form, and there's also an opportunity for the bowel to twist on its base. Sometimes at the base you find an adhesion. It maintains the loop morphology, and all the thing has to do is twist at its base. This type of volvulus pattern, typical volvulus pattern, is very common in people who are chronically constipated. People chronically constipated, the bowel is generating a lot of peristaltic action. Sometimes it'll twist on itself like this. Then we have another pattern of volvulus. It's called an axial volvulus. Okay, it twists on its own longitudinal axis. This is an example of the typical volvulus that developed in the ascending large bowel. You can see right here, the bowel is literally twisted on itself along the longitudinal axis. All right, let's take a look at an example of radiographic appearance of a volvulus. Take a look at a typical volvulus. Okay, here you can see an example of just a plain abdominal radiograph. No contrast agent has been used. Okay, you see something kind of funny here. There is this kind of U-shaped air density here, and you'll notice that there's kind of a density down here at the base. There are these enhanced walls here that are radiodense, and you see this big air density right in the middle. This is consistent with a sigmoid volvulus, a typical sigmoid volvulus. This is where most of them occur, right? The sigmoid colon. And this sign is called the inverted U sign. It looks like a U. Not necessarily looks inverted, but it's a U. Okay. Presentation we talked about, again, bowel obstruction. You get a severe abdominal distension. Probably you'll develop bilious vomiting, especially if in the case of obstructions occurring distal to the duodenal suite. Okay, you'll have bile in the vomit because everything from the lower GI tract is going to come out. Also, that part of the bowel that's obstructed may be affected by ischemia, and so it may be necessary to resect part of the bowel. Maybe the obstruction can be relieved. Maybe it'll be as simple as that. However, if the bowel's been ischemically damaged, you'll have to resect that part of the damaged bowel. Any questions on bowel obstructions? Okay. Let's talk about tumors of the GI tract. Most of the tumors that develop in the GI tract are of epithelial origin. Something happens to the epithelium. Sometimes the epithelium overproliferates. Sometimes the epithelium becomes dysplastic. Whatever be the case, usually it's the epithelium that causes a tumorous mass to develop in the GI tract. Rarely does a stromal component cause a mass to develop in the GI tract. And so most of these tumors are of epithelial origin. Okay? Of the tumors that develop, most of them develop in the lower GI tract, specifically the large bowel. Many different types of masses that can develop. Take a look at these. Some are neoplastic, some are not neoplastic. Okay, some typical types of tumors, remember tumor just means bump, it does not mean neoplasm. Some of the types of tumors that develop are hyperplastic in the etiology. This typically is caused by the epithelium overproliferating, not in a neoplastic way, but hyperplastic. Sometimes there's a problem with maturation. This can be caused by constant inflammation affecting the epithelium. The epithelium just overproliferates as a result of overgrowth, an overproduction of growth factors, causing the epithelium to become hyperplastic. Other forms of non-neoplastic polyps include hamartomas. Remember what a hamartoma is? Hamartoma. Define a hamartoma. Just a lump of disorganized tissue, that's it. Lump of disorganized tissue, nothing neoplastic about it. Okay, a number of different types of hamartomatous polyps we'll talk about. Then we have the neoplastic polyps. These are true neoplasms. Most of the types of neoplastic polyps we'll see are adenomatous. They're benign proliferations of glandular tissue in the bowel. The epithelium of the bowel is glandular. And so if the glandular epithelium becomes neoplastic, it's an adenoma. Okay, it's benign, it's an adenoma. The problem with these benign adenomas is that it's thought most bowel cancers evolve from. These adenomas can undergo malignant degeneration and develop into adenocarcinomas. And again, most bowel cancers are thought initially to evolve from these benign adenomas. All these other types of masses, mesenchymal lesions, i.e. stromal tumors, they're pretty uncommon, so we're not going to talk about them. They're not constant pathologies. All right, any questions on that? Let's talk about the polyps first. Again, we've got non-neoplastic polyps, and we've got neoplastic polyps. Generally, you see these polyps in two different morphologies. They're sessile and pedunculated. Let's take a look at that. Let's look at the pedunculated first. So here's a depiction through the bowel wall. You got the lumen over here. You can see the mucosa, that's the submucosa, there's the muscularis propria. Arising from the bowel lumen, you can see this mass that has a head and a stalk. If that mass has a head and a stalk, we describe the morphology as being peduncular. Then there's another morphology called sessile. Again, same thing, except the mass has a head with no stalk. Okay, if it has a head, it doesn't have a stalk, described as sessile. Sessile morphology. Okay, we just have this kind of protruding bump, the head with no stalk. Okay, let's take a look at some of these different polyps that can develop. Again, most of these polyps we're talking about develop in the colon. They can develop in the small bowel. Most of them are in the colon. Okay, we have pedunculated sessile forms. Let's talk about the non-neoplastic polyps first. They are by far the most common type of polyp. Okay. About 90% of polyps are non-neoplastic. They're highly prevalent in people over the age of 60. Most of these non-neoplastic polyps are developing as a result of some problem with the epithelium and the mucosa not maturing properly, possibly because of some chronic inflammatory process. They're not malignant, they have no malignant potential. Some of these different types of non-neoplastic polyps include the hyperplastic polyp, which I just mentioned. There are also some hamartomatous polyps. Juvenile polyps, probably heard of these. Juvenile polyps. These are hamartomatous polyps that a person is generally born with. Okay, they're just lumps of disorganized tissue. They're generally past by the time the person makes it to adulthood. Fecal material passing through the GI tract will excoriate the polyp and generally breaks off the polyp, and the polyp is passed, and that's the end of it. If it is retained into adulthood, we call them retention polyps. Then we have Peutz-Jeghers polyps. These are hamartomatous polyps that are associated with a specific genetic disease called Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is caused by a defect in the STK11 gene. People with this gene mutation have kind of some odd, interesting presentations. The first thing you'd notice about someone with Peutz-Jeghers syndrome is that they have odd melanocytic lesions around their mouth and on their lips. Here's an example of someone with Peutz-Jeghers syndrome. This is what you would notice about them first. Again, you have these heavy concentration melanocytic lesions around the perioral region and on the lips. If this person does have Peutz-Jeghers syndrome, you'd expect their colon to be filled with a lot of hamartomatous polyps. Okay? These hamartomatous polyps can cause significant trouble. They get excoriated, they bleed, sometimes they'll cause intussusception. Okay? That's some of the problems with Peutz-Jeghers syndrome. They don't really have a high potential for malignant degeneration because they're not neoplastic to begin with. They're just hamartomatous. All right, any questions on non-neoplastic polyps? Now, non-neoplastic polyps, they have no malignant degenerative potential, generally speaking. They still can cause problems. The main problem with a non-neoplastic polyp is that they bleed. If they're hanging out in the bowel, they're in an exposed position, so stool comes by, excoriates the surface, and they bleed. The other thing I mentioned, their intraluminal mass, they can cause intussusception. Those are some of the major problems. If someone has neoplastic polyps, and you know they're neoplastic polyps and they're not causing any problems, you just leave them alone until they cause. It's only when they're actually bleeding or they're causing other complications that you would even trouble yourself to resect them. The bigger problem with the neoplastic polyps, the adenomas. The adenomas have malignant degenerative potential. So when you find them, you have to resect them. They're a risk for cancer. We consider them precancerous. We have to do something about them. They're invested by a dysplastic epithelium that has presumably a high rate of deterioration into a locally invasive adenocarcinoma. Take a look at some of these neoplastic polyps. Here's an example of a neoplastic polyp that has a pedunculated morphology. Section 2 polyp, you can see there's the head, there's the stalk, the bowel wall would be down here. And you can see stalk and head, it's pedunculated. Now, generally, if we look at the histology of this polyp, we would find that the stalk is actually invested by a normal epithelium. This is a normal colonic epithelium. The core of the stalk would just be fibrous tissue and a lot of vasculature. There's no real problem with the stalk here. The problem is up here in the head. The head is invested by an epithelium that's dysplastic. And this has the potential for degenerating into an adenocarcinoma. This happens to be a polyp that we call a tubular adenoma because the glands of this polyp, they make these little tubes. So it's called a tubular adenoma. So we call this a pedunculated tubular adenoma. Pedunculated refers to the morphology. The tubular refers to the histology. Let's have a closer look at that epithelium. We'll show you that it is indeed dysplastic. Okay, and this is where the problem comes. So we'll take a section right there. Here's a close-up of the epithelium. Okay, so we got the lumen of the bowel out here. Again, we're looking at the head of the stalk. You have both normal as well as dysplastic epithelium. Here's some normal epithelium. That's the normal limits right there. You can see the cells are columnar in the microvillus brush border. They're evenly spaced. Everything looks good. They're monotonous looking. That's the way they're supposed to look. They're not overcrowding each other. Evenly spaced, normal morphology. Over here, though, you can see part of the epithelium which is not normal. How would you describe those cells? They're very crowded. Yeah, they're crowded. That's pretty crowded, and of course that's one of the problems with neoplasm. Cells overcrowd each other. So this is an intraepithelial neoplasm. Okay. These cells are still sitting on the basement membrane they're respecting. As long as they don't punch through that basement membrane and invade into the lamina propria, it's not a cancer. It's just a dysplastic lesion. And it's a dysplastic epithelium, it's neoplastic epithelium, whatever you want to call it. That's the epithelium, though, that has the potential for degenerating. Okay? If it does, it's going to break through that basement membrane and it's going to invade the lamina propria here, and we call that local invasion. And you know local invasion is the defining feature of malignancy. It's no longer an adenoma, it's an adenocarcinoma. So this is what we are afraid of with these adenomatous polyps. That's why when we see them, we have to resect. They have too much of a potential for developing into a bowel cancer. Let's take a look at the radiographic appearance of these polyps. Here's an example of a double contrast study. This is a lower GI series. It's barium. And we get a double contrast study. We're using contrast agent in air to see the polyp. So we give this person barium enema. Then we ask the person to evacuate the barium, and then we inflate the bowel with air. And you get this kind of nice pseudo 3D image. You can see there's the rectal vault there. You can see the sigmoid colon over here. That's the descending colon. Of course, that's the transverse colon. Everything looks good except for this part of the descending large bowel. You can see there's a polyp there. What morphology does it have? Pedunculated. You can see the stalk here. There's the head there. And you can see it's a pretty sizable polyp. And you can imagine this part of the GI tract. Stool's going to be probably semi-solid. It's going to come through here. It's going to excoriate the surface of that polyp, and the polyp's going to bleed. And so the person's probably going to see some dark red blood as soon as it's passed. And that's probably going to cause some problems, probably going to change bowel habits, probably going to cause bleeding. This happens to be just a non-neoplastic polyp, and so even though it is a non-neoplastic polyp, because it's causing trouble, it would be resected. Now this is an example of how the polyp would look on a double contrast study. Usually we wouldn't go that far, we just do a single contrast study. This is what the barium enema would look like before we ask the person to evacuate the barium, like with air. Again, you can see there's the rectum there. Sigmoid colon. Look how much redundant link you have in the sigmoid colon. This is why this is a common place for volvulus to develop. You got descending, transverse, ascending, and you can see the ileocecal junction. This is the terminal ileum over here, and that looks like the appendix right there. And if you look again in that same area of the descending bowel, you don't see that nice, pretty pseudo 3D picture of the polyp. But what you do see is, what do we call that? Radiographically, how would you describe that?
CISA.
Filling defect. It's a filling defect. And that's where the polyp is, just displacing the dye. Okay, any questions on polyps? Non-neoplastic, neoplastic. Okay, and again, non-neoplastic, no risk for transformation, but the benign, neoplastic polyps, they have a potential for developing into adenocarcinomas. All right, so let's take a look at, again, I think we went over presentation. Let's just re-emphasize the presentation of these different polyps. They can be asymptomatic, they can cause bleeding, sometimes they get twisted, they can cause bleeding, they can be passed, they can cause pain. Some of these polyps, particularly the adenomas, these benign neoplastic polyps, they can produce heavy protein secretions. Someone can develop hypoproteinemia as a result. They also produce heavy secretions heavy in potassium, so they can become hypokalemic. And we already talked about obstruction and tussoception. So the workup, they're probably gonna present with some form of blood in the stool. That might be what brings them, otherwise these things might be asymptomatic. So you'll perform a fecal occult blood test. If there are other problems, you don't know there's blood in it, you can do a sigmoidoscopy. Again, if you don't know the nature of a polyp, you may have to investigate the person has lots of polyps, you may have to investigate the nature of the polyp. Maybe you'll take 1 or 2 polyps just to figure out what kind of polyps they are. If they're non-neoplastic, unless they're causing trouble, you leave them alone. If they are neoplastic, you have to go back and resect all of them because they are a risk. Okay. Colorectal cancers. Most of these are adenocarcinomas, and most of these are thought to develop from malignant degeneration of the adenomatous polyps. They have a variety of different morphologies in which they can grow. They can grow as a mass, obstruct the bowel. They can kind of grow as an infiltrating mass. They can grow in an annular distribution, meaning around the lumen of the bowel. Let's take a look at the example of an adenocarcinoma that grows in an annular distribution. It means around the interior of the bowel. Okay, this is a resected segment of large bowels where most of these cancers develop, rectosigmoid. Again, you can see some normal bowel over here. You're looking down at the mucosal surface. Look at the mucosal folds. Okay, all normal over here. But you also notice that there are some polyps here. I can't really see that one too well. I guess there's one over there. Oh, there's a big one right over there. Lots of polyps in the area. And right in the middle of these polyps, you see this ulcerating mass that's distributed in an annular distribution. Okay, that is the adenocarcinoma. It has classic malignant morphology. It's got a cratered center and it's got these margins which are not coplanar. So this will be described as centrally cratered with heaped up margins. That's classic malignant morphology. And of course, this is an adenocarcinoma. You can take a look at the adenocarcinoma section through the bowel. This is a section through the whole bowel. And we're actually looking right down here into the muscularis propria. This whole thing is the muscularis propria. What's wrong with this picture? This is muscularis propria. See a smooth muscle. What else? What's wrong with this picture? It's right through the muscularis propria. What kind of cancer is this? Adenocarcinoma. So what would you expect? Glands. Do you see glands here? Yeah. It's digging right down into the smooth muscle. Since when do you see all these glands and smooth muscle? Look at this. Look at these glands. They're all over the place, and they're atypical. I mean, they're everywhere. And look at the epithelium that they're made out of. Would you say those cells are all crowded together? Yeah. That's neoplasm. They look pretty bad. That is an invasive adenocarcinoma. Look how bad they are. So now you've got these glands digging down into the bowel wall. And it won't take long for these things to go right through the bowel, metastasize to the local lymph nodes, and then the horse is already out of the body. Right, how do these things present? It really depends on where in the bowel the cancer is developed. It can develop on the right, it can develop on the left, it can develop very distally. That's going to, of course, determine what the first presenting symptoms are. Generally, one of the most common presenting features of a bowel cancer is going to be an iron deficiency anemia. These things bleed. And they may bleed subtly, resulting in an occult bleed. What do I mean by an occult bleed?
in your stool? It's in your stool?
It's in the stool, but what do I specifically mean by an occult bleed? Occult. Occult. It's
not easily seen.
It's not easily seen, so it's basically developing, you're developing a bleed that you can't really detect, at least not with the naked eye. And over time, that could result in anemia. In fact, that's such a common way for a person to present with bowel cancer, with an iron deficiency anemia. If you have the right person, the right age, the diagnosis is bowel cancer until you prove otherwise. Typical person who develops bowel cancer is going to be somewhere between the age of 60 and 70. If you have a man in the age range of 60 to 70, and they're presenting with an iron deficiency and anemia, that is bowel cancer until you prove otherwise. It's such a common way for the bowel cancer to present. Now, if you have a woman in that age range, bowel cancer is in the differential, but it can also be some other things. But if you have a man, age 60 to 70, with iron deficiency anemia, and that's how they're presenting, that's bowel cancer until we rule it out. Okay. Again, generally most people will present with bowel cancer in that age range, 60 to 70. If they're developing bowel cancer earlier than 60 to 70 years of age, then they have some sort of antecedent condition, most likely that allow them to develop it earlier. For example, they can have ulcerative colitis maybe. If they have ulcerative colitis, that would increase the risk for developing bowel cancer. So usually if someone, for example, develops bowel cancer and they're 45, there's probably a reason for that. Rheumatoid bowel disease, it could be something else. But usually the presenting age range otherwise would be 60 to 70. That's the most common age. Okay, let's have a look at the radiographic appearance of a bowel cancer. Here's an example of a bowel cancer. It develops, again, in an annular distribution. It happens to be developing on the right side. Okay, when someone develops bowel cancer on the right side, usually the symptoms are very vague, general symptoms. Maybe an iron deficiency anemia, maybe fatigue, but usually they won't present with things like changing bowel habits until very late in the development of the cancer. Let's take a look at this. We have a lower GI series, rectal vault. Again, look at the sigmoid colon. Look how much redundant length you have in the sigmoid colon. You develop a loop and twist on it. That's why volvuli are very common here. There's the descending transverse, and there's the ascending bowel. Just distal to the ascending bowel, you see that. That's a filling defect. And you can see an extensive filling defect. Looks like the bowel stricture here. This is where the cancer is developing. The cancer is developing around the entire lumen of the bowel, and it's protruding inward, and it's displacing the dye. And so now you have this small area that's radiopacified. What's that lesion remind you of? The appearance. Anybody? A what? Did you say a sandwich?
Because that's the top red and then that's the bottom red.
Oh, a sandwich.
I don't know. That's what I see.
Well, I guess you're thinking of food. I guess that's along the right line. Anybody else?
Are the cooling.
Yeah. How about an apple after you eat it?
Oh,
Apple core.
Apple core.
Like an apple
That's what
core.
it's commonly called, an apple
See,
core.
I was looking at the wrong part too. That's also why I got a sandwich.
Ah.
You were.
Well, you're close. You can have an apple with your sandwich.
You can.
All right. So anyway, that's an apple core lesion there. Now, again, something like this, cancer developing in this area probably will present with very vague symptoms. Again, fatigue, iron deficiency anemia. That will, of course, clue you in if the person's in the right age range, 60 to 70. Maybe they have a bowel cancer. The one thing you would expect, perhaps, from a stenotic area of bowel, why doesn't it change the person's bowel habits? Shouldn't they be constipated? They have a strictured area. The problem with the cancer developing here on the right is that the fecal material is still very fluidic and pasty. It can even negotiate a small area like this. And so as a result, when bowel cancers develop on the right, it's usually with vague symptoms, nothing necessarily you can connect with bowel, unless, again, the right age range they're presenting with iron deficiency anemia. If, however, the cancer is developing over here on the left side, the fecal material is solidified here, a strictured area would definitely cause some change in bowel habits. And you would know immediately, yeah, there's something wrong with the GI tract. Okay, so we start with GI, and of course work your way from there. The symptomatology of cancers developing on the left side would be a little more specific to GI as a result. Any questions on this? Let's talk a little bit about some general things. Again, most of these are adenocarcinomas. Generally, peak incidence is between 60 and 70 years. Anyone getting it earlier probably has some identifiable antecedent condition like UC or Crohn's. Presentation. These things grow actually pretty slowly. They might be developing for years before they actually become symptomatic, particularly if they're developing on the right side. Okay, right-sided cancer, fatigue, weakness, iron deficiency anemia. Left colon cancer, changes in bowel habits in addition to everything else. Okay, sometimes they also develop in the rectum. Okay, generally people will be passing bright red blood because these cancers bleed. Okay, you'll be able to see the blood. It might cause some local irritation, resulting in a proctitis. When the rectum is inflamed, it's called a proctitis. The proctitis results in tenesmus. Anybody know what tenesmus means? It's, what's that?
It's like a frequency, urgency.
Yes, the feeling that you must defecate, but there's nothing in the rectal vault. So it's a feeling you have to bear down, but there's nothing there to move. That's tenesmus. That's a classic symptom of a proctitis. All right, we talked about the iron deficiency. Remember, right age range, male.
The BRB PR that we have in the notes is the bright red pouching.
Bright red blood per rectum.
Okay, thank you.
Bright red blood per rectum. That's a common abbreviation. Bright red blood. And metastatic disease, go to the regional lymph nodes. It's a very slow growing cancer. Okay, the workup. Detection and diagnosis, screening, rectal exam. Generally, people should have a rectal exam every once in a while. While you're having that rectal exam, some fecal material should be sampled and it should be tested for blood. The most common test we use is the occult hemoglobin test. Are you familiar with that? Generally, if you don't know about it, it's a test where we take some fecal material, we put it on a card, and then we can develop the card with a solution. If the card turns blue, there's hemoglobin. The thing you have to be careful with is if people eat red meat, the hemoglobin in the red meat actually might turn the hemoglobin test positive. So you just have to ask what the person had the previous night or last few nights. Staging. Okay. Ultimately, you're going to get an endoscopy and a biopsy. Okay. Staging. How's he going to do that? You want to know the depth of wall invasion. How far down has the adenocarcinoma dug into the bowel of the wall? That's going to be an important staging factor. And of course, you want to assess for any kind of regional or distant metastatic spread. You can do that with a CT scan to check out for the regional lymph nodes, chest radiograph to see if any mets have gone to the lungs, and you can get some liver function tests to see if there might be any evidence of metastatic disease to the liver. These are bowel cancers. The bowel is drained by the portal venous system. So if any cancer is going to metastasize, it's going to go into a vein first because they are the thinnest walls compared to the arteries. And the portal vein services the GI tract, so it'll get into the portal vein, it's gonna go to the liver. So your best bet would be to check liver. But it also goes to lungs, so that's why we screen for those things. Okay, any questions on that?